Thank you very much for the introduction. Hello, everyone. Thanks for joining. I'm Roman Zuckerman, as Parminder said. I'm a rheumatologist with Valley Medical Group in Ridgewood. We're located at 1200 East Ridgewood Avenue. So today we're going to talk about fibromyalgia. Just a kind of a brief overview of what we're going to cover today. We'll talk about what is fibromyalgia? How does it present? What are the associated symptoms? We'll talk about some of the diagnostic criteria, how we as rheumatologists diagnose fibromyalgia. Then we'll cover some of the associated conditions, coexistent conditions, as well as risk factors predisposing to developing fibromyalgia. We'll discuss some of the mechanisms involved in development of fibromyalgia, the current science behind it, as well as we'll then segue into treatment, and we'll cover some of the both non-pharmacological as well as pharmacological approaches to managing fibromyalgia. And then, as Parminder mentioned, at the end of the talk, we should have a few minutes for some questions. So let's get into it. As you can see on the slide, I don't have any disclosures or any conflicts of interest. So let's start with how does fibromyalgia present? So it's chronic, and that's, in red I highlighted greater than 3 months. It's important that the symptoms have to be there for a relatively prolonged period of time, at least 3 months. Widespread, diffuse body pain. Associated symptoms are muscle soreness, tenderness, often burning, tingling, stiffness, as well as these other symptoms that I've listed on the slide: fatigue, poor sleep, waking up tired, unrefreshed. Patients often experience cognitive symptoms like certain mild memory disturbance, some concentration issues, focusing issues. The mood is often depressed. They're experiencing headaches, and they're very sensitive to various stimuli such as bright lights, certain noises, as well as strong odors. And then, dry eyes. We often see dry eyes and dry mouth often coexisting in patients with fibromyalgia. Now, when I mentioned the pain, the chronic pain, diffuse body pain, I just want to touch upon this whole concept of pain and differentiate the fibromyalgia type pain from other pain that most of us as humans experience. So the pain is, in a simple way, broken up into 3 different types of pain. Nociceptive pain, and that is essentially pain from any type of mechanical trauma. So let's say if you have a minor cut, you feel it's a cut, it's painful, that's how you perceive the pain. Or if there's, let's say, inflammation in one of your joints, let's say in the rheumatoid arthritis, a swollen joint, or gout, acutely swollen joint, that's obviously painful, and that would fall under nociceptive pain. Neuropathic pain is somewhat different. The distribution of pain is quite different from nociceptive pain. Oftentimes it's symmetric, and it follows this what's called stocking or a glove distribution pattern. In other words, pain often involves, let's say, both hands, and it is worse at the periphery, let's say, at the end of your extremities, by the fingers, and then kind of goes up towards your arms. Now, the centralized pain, this is the type of pain that is most commonly associated with fibromyalgia. And the reason why we call it centralized is because the pain is not coming from the periphery. It's not coming from where the injury is. It's not coming from where the inflammation is or where certain nerve damage is. The pain is actually coming from your brain. So here's a slide, and that's, I don't know if how familiar people are with fibromyalgia, but tender points used to be one of the diagnostic criteria, how we as rheumatologists or primary care physicians would normally examine patients, and that would be part of the diagnostic criteria to look for these tender points. Now, what are these tender points? They're essentially located where the muscle intersects with the tendons, and they are generally sensitive points. In other words, you don't have to have fibromyalgia. These are relatively sensitive points to anyone. However, in patients with fibromyalgia who are overly responsive to pain, overly sensitized to pain, these points are extremely more sensitive than to a normal human being, and in fact, they are painful. Now, the reason I'm bringing this up because this has been in use for years. However, it has been most recently phased out, so it's not a part of the diagnostic criteria anymore, although we still use it when we evaluate and see our patients, but officially it's not part of the diagnostic criteria. So it's interesting with the new diagnostic criteria, which I've just listed I'm showing you on this slide. The men with fibromyalgia a lot more men are now being classified with fibromyalgia, and the reason is because men don't tend to don't tend to have a lot of these tender points compared to women. So these newer criteria, I mean, these are, you don't have to try to read any of through these slides. I'll just briefly mention what we look at. There's diagnostic criteria. This is all patient driven. The patient essentially answers these questions, and what we'll look at pain index. We'll look at how many spots patient reports as being painful, and then we also calculate what's called the symptom severity score. I don't know if you can see all the way at the bottom right and the middle right. Patients score how fatigued they are, how severely unrefreshed they are when they're waking up in the morning, as well as they also rate their cognitive symptoms, certain concentration problems, memory problems, as well as what's called some somatic symptoms, things like headaches, how poor their sleep is, diarrhea, abdominal pain, vision problems, anxiety. And so then we put these scores together and come up, if the scores do reach a certain threshold, then it's safe to say that the patient has fibromyalgia. Again, these are criteria mostly used for studies, so it's not it's not always cut and dry in real practice. There's a little bit of art to this, but generally these are the new criteria. So tender points, so the point I'm trying to make here is that the tender points, which were central to diagnosis of fibromyalgia in the past, not so much anymore. So what is fibromyalgia? So just a little bit of statistics. In the United States, approximately 6 million people have fibromyalgia. Women are significantly overrepresented. And generally, we see patients with fibromyalgia between ages of 20 and 55. You can see younger patients. However, it's important to mention that whenever we see a patient over the age of 55, and there's no hard cutoff, you always have to be careful to diagnose someone with de novo. With new fibromyalgia, always have to make sure there's nothing else organic going on, such as infection, any type of cancer, any other inflammatory condition. Now, a question always comes up when patients ask, are there any diagnostic tests currently available for diagnosing fibromyalgia? And I will tell you, so this area is still very much in the development. There is a test currently available that has been available for the past several years out of University of Illinois. They're still refining it. They're still working on it. In fact, they are working on a study. There's a study that's being done out of Harvard where they're inoculating patients with a BCG vaccination, which is not really used in the United States, but used in developing world against tuberculosis. Patients are receiving once yearly a BCG vaccination, and they're comparing them to control patients to see if they're have an improvement in their symptoms over time. So it's the same group that's developed this test, FM/A. They're working on this Harvard study at Harvard. As far as imaging, again, also a relatively new area. Functional MRIs are being used, not so much to diagnose fibromyalgia, but at this point, they're trying to look at patient's brain and various parts of the brain and see how differently do they respond in patients with fibromyalgia versus patients without fibromyalgia. And then some of the results are relatively varied at this point, so it's really hard to say, we can use functional MRI for diagnosis, but potentially predicting treatment response, that's something where it could have some utility. And it's important to recognize that fibromyalgia is not a psychological condition. So what are some of the associated conditions and syndromes? So patients with fibromyalgia can also suffer from TMJ, irritable bowel syndrome, interstitial cystitis, what's now called irritable bladder syndrome, vulvodynia, tension or migraine headaches, cognitive impairment, or what's often called fibrofog, as well as restless leg syndrome. Some of the predisposing factors and conditions, so environmental, social, cultural, behavioral variables, there's quite a few of them. And that's, when we see patients, we often see it, the patients recognize that a lot of these things overlap and, they're coexist with fibromyalgia. And a lot of them are, triggers, something that patients have lived with for years. So things like depression, anxiety, certain early life developmental experiences, childhood abuse, certain family variables, spousal family support systems, obviously work-related stress, job satisfaction, certain personality traits. So patients who are more of perfectionist nature, self-sacrificing personalities, those who often catastrophize, those who have a lot of negative beliefs, and in other words, more pessimistic about their condition, about their pain, and a few others I guess I listed on the slide. There's low self-efficacy, those who have do not have good coping mechanisms. That's critical. In other words, not having good support system, inability to cope with your symptoms and pain. Now, it's important to recognize that, especially in the rheumatology world, I've listed, you can see here at the top of the slide, those are what I call comorbid conditions. You have patients with inflammatory conditions such as rheumatoid arthritis, Sjogren's disease, psoriatic arthritis, lupus, and so on. Patients often have coexisting fibromyalgia, not uncommon at all. I would say on average 30% of patients with inflammatory conditions such as rheumatoid arthritis often have fibromyalgia, and it makes it sometimes difficult for the physician to decipher and to see, is this their underlying rheumatoid arthritis that is flaring up, or is it all fibromyalgia? I did list Lyme disease here as one of the coexisting conditions, and that's very important because that's a quite controversial topic, I think, in the community. We often see patients that have had Lyme disease in the past, and they come to us, and this concept of chronic Lyme disease, In fact, that's what's very controversial, especially in the rheumatology and infectious disease world. But we call this what's called post-treatment Lyme disease syndrome, and that often resembles fibromyalgia, and most of the time treated as a fibromyalgia patient would be treated. There's also some biologic variables, certain genetic mutations. Female sex is a risk factor, as you saw in the previous slide. Women are significantly overrepresented, 80% versus men 20%. And then there's some other things in neuroendocrine response to stress, a certain decreased amount of certain neurotransmitters that are normally involved in decreasing the stress levels, decreasing the pain levels. Those who are deficient are predisposed to developing fibromyalgia. So how does the fibromyalgia develop? So the symptoms result from, as I list on the slide, abnormal pain perception. So there's amplification of pain. I'm going to kind of jump between two slides real quick. So here's a graphic depiction of what we're talking about. So you have a stimuli that comes in from the periphery. This is, let's say, your skin all the way, that box on the left. And, this stimulus might not be painful initially, but there's this barrage of stimuli that keep coming in, and they're then processed through the spinal cord, then they go up to the brain. I'm going to jump back to this slide again. And eventually what happens is, so this what's called peripheral sensitization. You have this enormous amount of stimuli that keep coming in, which are not normally perceived as painful or unpleasant, but eventually the system becomes oversensitized, and so overwhelmed, so to speak. And then there's persistent hyperexcitability of nerve endings. And so, as I was saying, they go up to the spinal cord, then they further they go up to the brain, and the brain becomes overwhelmed, thinking that many of your muscles and joints are essentially on a hot stove. Now, at the same time, it's important to note that there are certain pathways that are coming down from the brain that are supposed to dampen the response. They're supposed to provide what's called analgesia, so to speak, and the neurotransmitters responsible for that are norepinephrine, serotonin, and dopamine. In patients with fibromyalgia, there's a decreased amount of those neurotransmitters, so they're essentially unable to dampen that painful response that is being sent up to the brain. Down at the bottom on the right in red, I listed a very insightful lecture by Dan Claw. He's a world authority in fibromyalgia out of University of Michigan. You don't have to write down this YouTube. You can just YouTube address. You can just Google. You can just go to YouTube and search for Dan Claw, and you'll find several of his lectures. And it's rather long, but it's an excellent overview of fibromyalgia and chronic pain. So again, just to kind of recap on this slide, you've got a lot of stimuli going up. You have on the left with the plus sign certain neurotransmitters that are increasing the pain perception, and those are increased in patients with fibromyalgia. Whereas on the on the left with the plus sign, whereas on the right with the minus sign, those are the ones that are supposed to dampen the painful response. The ones supposed to give you the analgesia, those are decreased: norepinephrine, serotonin, and dopamine. So let's move into treatment and management of fibromyalgia. So in 2017, European League Against Rheumatism, which is a pan-European society of rheumatologists, similar to American College of Rheumatology, they've come up with this they had this, did this massive project where they reviewed, hundreds of papers evaluating various modalities, both pharmacological and non-pharmacological, and they rated them in terms of how much efficacy they think they will provide. And at the top of the list, and you can see this on the slide, there's only one strong recommendation that came out of that undertaking. The exercise and activity, or exercise/activity, essentially was the only one that earned their strong recommendation. There were quite a few other ones which we'll go through, but nothing else measured up to exercise. So graduated approach, aerobic exercise, strengthening exercise. So, and again, what the recommendation is, the initial management should focus on educating the patients, discussing the symptoms, talking about the condition, obviously treating the coexisting conditions, things like inflammatory conditions, depression, anxiety, working on improving the sleep. So non-pharmacological treatments such as exercise, as I mentioned, aquatherapy, and then beyond that, if the patient is still having symptoms, still hasn't improved, then pharmacological therapy is appropriate at that time. But nevertheless, the approach is multi-pronged, so to speak. You continue doing the non-pharmacological things after you move into the adding medications. So here's a slide right out of that paper, and you can see I've had that circle up there, oval, where it highlights that aerobic and strengthening exercise is the only recommendation that they rated as strong. So let's talk about sleep. Sleep is central to fibromyalgia. Sleep is central to managing fibromyalgia. I always talk about my patients. I always talk to my patients about sleep. 70 to 80% of fibromyalgia patients experience sleep problems. And what are the consequences of poor sleep? Increased fatigue, increased pain, decreased concentration, worsening depression and anxiety. And let's talk about some of the causes of poor sleep. The very basic thing, and that's we always discuss this at our visits. We talk about sleep hygiene. We talk about decreasing the any type of stimulation before bedtime. Things like avoiding caffeine, alcohol, eating before bedtime, any type of engage in exciting activities, TV, computers, and obviously the old favorites these days, the cell phones. But then there are other organic conditions such as sleep apnea and restless leg syndrome. I'm using two examples here that can certainly interfere with your sleep. So we always talk about when a patient comes in, I always ask the patients, do you snore? And that's potentially a sign of sleep apnea. And if the patient snores, sometimes you don't even have to. Sleep apnea is often associated with being overweight, having wide neck. In fact, that's not the case. You can have sleep apnea and be of normal weight, with normal size neck. So then, in that case, we often refer patients to a sleep specialist to get a sleep study, because that could be the culprit that interferes, that causes the poor sleep. So let's talk about some of the good sleep behaviors. And I apologize, this slide is, the font is rather small, a little bit limited in terms of, technology is tough these days, limited in terms of number of slides that I was able to incorporate, so had to cram in some information on the slide, but we'll go through it slowly. So associate bad with sleep, not frustration. Don't go to bed until you're sleepy. If not asleep in 15 minutes, get out of bed. Try again when you are sleepy. Again, as I mentioned on the previous slide, bed is for sleep. It's not for activities such as TV, cell phones, reading, or eating. There should be no TV screens in the bedroom. The temperature should be relatively cool. You shouldn't feel hot in the bedroom. And as far as following a certain preset schedule, that appears to have good outcomes. So try to go to bed around the same time every night. Try to establish a regular sleeping pattern, and then the body essentially learns that regular sleeping pattern. You can use alarm clocks. You can use your phone to set the alarms. And it's important. Obviously your family needs to be aware. If you understand how important sleep is to you and to fibromyalgia, your family should understand that you don't just want to rest. You want to rest because that will potentially improve the overall fibromyalgia. So that it's important that the family members are kind of all in on this as well. Trying a warm bath 20 minutes, half an hour before bedtime. That's useful. Certainly not exercising right before bedtime, so you're not overly excited. And then avoiding things like napping during the day. And I think we already covered the other stuff. Caffeine, smoking, eating before bedtime, and alcohol. So now let's segue into medications in fibromyalgia. So just a few pearls about medications. There's some statistics here, and about 50%, about half the patients will respond to medication. So it's important to recognize, I always kind of go back to the same thing, is that it's not all about the medications. And here is the proof is that patients that do take medications, only half of them have some kind of response. And out of those patients, only about half the patients have good, solid response to their medication. So kind of puts it in perspective that medications can only get you so far. They are useful to treat some symptoms. No magic pill to treat all the symptoms. They do take time to start, so it's very important to recognize that you come into a physician, you expect things to essentially turn around within a week or two. It doesn't usually work that way. It's important to discuss it with your health provider. You would need to we recommend keeping a diary of your symptoms in terms of improvement or worsening. We usually start low dose. Again, we want to let the medication work. The other reason why we want to start a low dose is because we don't want the patient to suffer side effects very quickly and then give up on the medication. Often the recommendation is to take the medication 2 to 3 hours before bedtime, and that's, again, we'll talk about some specific modalities, specific medications. I'm talking about those medications that are taken before bedtime that help with sleep. Again, so as far as worsening symptoms, it's quite variable. It could be a natural cycle of fibromyalgia because the symptoms do wax and wane. And so it's important not to just assume that it is that new medication that's causing the worsening symptoms. And we often ask, don't give up on the medication. So antidepressants are often used to treat fibromyalgia, and in fact, some of them are approved to treat fibromyalgia. And the reason is because some of the same neurotransmitters, I mentioned them previously, the serotonin, the dopamine, they are the same ones that are involved in depression and in fibromyalgia. So the first line medications, they're what's called serotonin norepinephrine reuptake inhibitors. So Cymbalta, or the generic name is duloxetine. So this is the medication that is approved both for depression, for fibromyalgia, as well as for osteoarthritis. So it works well for fatigue, but as well as patients who have underlying osteoarthritis. Savella, that's another medication that's approved for fibromyalgia. This medication also works for fatigue, but not so much for sleep, but also for fibro fog, some of these cognitive symptoms like memory, concentration, as well as for pain. And then the anticonvulsants, Lyrica. I'm sure many of you have heard of Lyrica. Gabapentin is a cousin of Lyrica. Those are the medications that we do use both for sleep. They're often used by neurologists for neuropathic pain. So I guess it depends on what the patient's presenting symptoms are. So the choice of the medication varies based on that. Then there's the old tricyclic antidepressants, amitriptyline, often primarily used for sleep, as well as pain and fatigue. And then there's the muscle relaxant Flexeril cyclobenzaprine, also used for sleep, as well as often for muscle spasm, muscle stiffness. And so these medications that are listed here that are used for sleep, those are the ones where I was mentioning before. So you don't take them right at bedtime, generally 2 to 3 hours before bedtime. So what about fatigue? Fatigue can be worse than pain. If you do too much today, you pay for it tomorrow. So the medications that work for fatigue, venlafaxine, also known as Effexor, duloxetine, that's Cymbalta, and milnacipran, that's Savella. Also bupropion, that's Wellbutrin. Again, these are all antidepressants. Modafinil. But it's important to recognize that you have to find what is the source of the fatigue. Where does the fatigue come from? Is a fatigue simply a symptom of poor sleep? Is there underlying sleep apnea or restless leg syndrome? What about sleep? Patients often wake up feeling unrefreshed, and again, that's usually a sequelae of poor sleep. So amitriptyline is often used for specifically as a sleep aid. It's a mild antidepressant. Cyclobenzaprine, Flexeril, muscle relaxant, but works very well for sleep if used appropriately. Trazodone, it is an antidepressant, but often used for sleep as well. So Lyrica and Neurontin, so pregabalin and gabapentin respectively, often we use them for sleep as well as for neuropathic pain. So tramadol is a tricky one. Tramadol is technically an opioid. It's a weaker opioid. It's not necessarily helpful for sleep. However, if the pain is primarily what's interfering with sleep, tramadol could be potentially beneficial. And then here at the bottom, I'm listing some of the more common sleep aids like Sonata, Ambien, Lunesta. But it's always it's never a first line to resort to the sleep aids. To work on improving the sleep. It's the sleep hygiene really what we hit on first before we resort to any pharmacological agents. So let's talk about some of the off-label medications. So I just mentioned tramadol. So it is a weak opiate. However, it does work similar to Cymbalta on the serotonin norepinephrine receptors, and it's helpful for pain. There are some Parkinson's medications and restless leg medications, the Mirapex, the Requip. interestingly, some data over the past 6-7 years in respect to low-dose naltrexone. So naltrexone is a blocker of opioid receptors, and it's used for opioid and alcohol use disorders. And it's, there were just very few studies where it showed that naltrexone can be helpful, not so much for improving the sleep or fatigue, but more so for improving the pain and decreasing the pain and improving the mood. Trazodone, I mentioned before, used for sleep, as well as modafinil for fatigue. And then there's the cannabis. That's what everyone, I guess, talks about these days. That's very much on everyone's minds. It's in the news. It's in the it's on our ballots in New Jersey. Let's talk about medications that are not helpful. So NSAIDs, naproxen, ibuprofen, Celebrex, meloxicam, Motrin, Advil, Aleve, they don't work for fibromyalgia. Narcotics, specifically opioids, oxycodone, hydrocodone, morphine, so Percocet, Vicodin, do not work for fibromyalgia. The interesting point I want to make is what the research has shown is that patients with fibromyalgia, they overproduce our endogenous, our internal opiates. Our bodies produce opiates. So patients with fibromyalgia have much higher levels of opioids that are produced by our own bodies. And so the receptors, the mu receptors, the opioid receptors, are already occupied by our own internally produced opiates. And therefore, the opiates that are taken externally, the Percocets, they just have nothing to bind to, and they have very little effect in patients with fibromyalgia. Steroids, prednisone, Medrol packs, they don't work for fibromyalgia. Patients can experience a temporary relief of their symptoms, but this is, it's an anti-inflammatory medication, but it also acts on your hypothalamus pituitary axis. So the patients that do experience some, temporary relief from prednisone, it probably happens through that pathway. But generally, this is short-lived. So cannabis, just a few words about cannabis, because there's so much, in the news. Everyone talks about it. Patients ask about this all the time. But I'll tell you where the science is at this point. Just a recently published study, literally, I just read it maybe a week and a half ago. It was a retrospective study where patients were asked to say what they use, what do they use the cannabis for? And in fact, pain is by far the most important aspect of the patient's symptoms, what they use it for. Pain, then sleep, and less so anxiety. So there's been several retrospective studies. So these studies that have not been controlled, in other words, the only patients with fibromyalgia were asked to answer questions, and those studies have shown some benefit. Patients do report improved pain, sleep, anxiety. There was one controlled study that looked at 3 different cannabinoid compounds, and in fact they showed no difference in terms of pain scores when compared to placebo. Nabilone is another marijuana-based compound, did show reduced pain as well as anxiety and improved sleep. And when patients come and they ask, what is our view on cannabis, it's hard to recommend for or against. Often patients come and say that I've been using, this CBD oil, and it's been working for me. So our recommendation generally is, if it's working for you, if it's not harming you, as long as, if you're not experiencing excessive side effects, it's probably okay to take it. Although, these products are not FDA regulated, so that's important to mention that. But if you were, if you do decide to use it, certainly one recommendation is to take it orally rather than smoke it, which helps you avoid the high. Definitely start at a very low dose, especially for those patients who are naive to cannabis. And that's important to look for products that are high in CBD and low in THC. With the THC component is the one that gives you the high. So let's talk about the exercise. And here I say exercise and activity, and that's a subtle thing, because it's we perceive exercise as going to the gym or going out for a run. It's really not just about exercise. It's literally just about it's all about activity. It doesn't have to be anything strenuous. So you can and you should be physically active. We often hear patients with fibromyalgia, they feel that they will make their symptoms worse if they exercise, or they perceive exercise as adding stress to the body. In fact, that's not the case. Less pain, improved function, better sleep quality, you feel better overall, and you're able to exert control over your symptoms. And as I just said, before, you don't need to work out hard. It's all about, starting to do something. It doesn't have to be anything significant. Even daily living, things like playing with children, traveling, working, all those things, they all count as activity, and they're all helpful. Obviously, having some structured physical activity, like low impact aerobic exercise, aquatherapy, those are great if you can find a place to do it. Obviously, much harder these days, with COVID. As far as patients who, often concerned if they're going to cause a flare-up because of the exercise and putting extra load on their joints or muscles, it's important to start slow, pacing yourself. If you have the ability to, work with a partner, work with a trainer, certainly great to plan the activity ahead of time. And then, don't overdo it. And you'll hear me say this a few more times in this talk. Definitely don't overdo it. It's important to, especially when you're starting out, it's critical to, pace yourself, do a little bit of physical activity, then rest. And so let's talk about some of the alternative treatments. So aquatherapy, I've mentioned it a couple times. It is generally available at Valley Wellness Center at MAWA. However, due to the pandemic, currently this is not being offered. Pilates is generally helpful. Several studies on yoga appears to be beneficial. Tai Chi, also a few studies have shown some benefit. Valley Wellness Center runs a Tai Chi class for fibromyalgia patients. Again, unfortunately, things have not restarted yet. We'll see, what happens with this, with the COVID season, where things take us. But hopefully, sooner rather than later, they'll be restarting that. Acupuncture, possibly okay. Again, some uncontrolled studies, mostly retrospective studies, where patients do report improved pain and fatigue, but I'm sure it's operator dependent, so to speak, and it depends where you go, who does it, so kind of at your own risk. The things that have not really shown benefit are massage therapy and chiropractic care. So let's talk about some of the relaxation and stress reduction techniques. So relaxation techniques increase your energy, production, productivity, motivation, certainly decrease your fatigue and stress hormone levels. It's important to teach your body how to relax. You have to be able to take control and be able to do it on command, essentially. And it takes a lot of time, takes a lot of practice. So some of the things I listed on the slide are just different modalities of how to essentially learn how to teach yourself, in a cognitive way, how to teach yourself to relax and therefore reduce the stress. So progressive muscle relaxation, a relatively new technique of guided imagery, relaxation, stress reduction, and generation of positive thoughts through images. Deep breathing exercises. Meditation is very helpful. Ability to direct your mind, to a specific event, concept, or object. Trying to shift away your attention from distressing thoughts. This concept of mindfulness, that's very popular these days. I have listed here Dr. Jody Katz. She's an integrative medicine specialist in MAWA. Also mindful.org, as well as this is an interesting approach. It's called mindfulness-based cognitive therapy. It was developed by Dr. Stuart Eisendrath. He wrote a book called When Antidepressants Aren't Enough. It's mostly geared towards patients with depression, and it teaches how to manage your symptoms, beyond medications. So in other words, how to break that cycle of negative thoughts. Obviously at the bottom here, I say that it's very important to do this on a regular basis, so it becomes, natural. So coping with fatigue. So the 4 P's of coping with fatigue: pace yourself, teach your body. You will not ask it to overwork, and say if you're shopping, if you're exercising, so 15 minutes of activity, 15 minutes of rest. Same thing with work. Important to prioritize tasks, chores, not to overdo it. Have only a realistic plan worked out for the day. Have patience with yourself, most importantly. And don't overdo it. And that's the critical thing, because overdoing it will stress your body and certainly will make you feel more stressed, will make you feel more depressed, and overall will make you not want to do it again. So as far as types of activity, anything light, walking, biking, swimming, yoga, tai chi I mentioned before, and certainly avoiding right before bedtime. Anything that's low impact, something that doesn't, not necessarily kickboxing or anything like that. That's I would probably avoid strenuous activities like that. Improving sleep habits, cutting back on caffeine. We talked about that. As well as treating your underlying. For those patients who do have anxiety and depression, it's critical to treat that, because this will have a significant effect on improving the fatigue. So cognitive behavioral therapy also appears to have quite a lot of benefit in fibromyalgia. And that's something that we recommend patients work with their therapist. Importantly starts with education about fibromyalgia, understanding the condition, what the symptoms are, how the condition progresses, how it can be improved, what makes it worse. Important to set the realistic goals for work and non-work related activities. Again, learning the relaxation techniques, behavioral pacing of activities. So don't overdo it, and certainly don't underdo it. And then strategies for prevention of relapses, and learning how to manage your flare-ups, because the flare-ups will come. As I was saying, the fibromyalgia is this waxing and waning type of condition where you kind of go, it comes and goes in waves. So it's important to know how to manage the flare-up when it comes, because they will come. So identifying that dysfunctional negative automatic thoughts, in other words, driving, they're the ones that drive the negative emotions and feelings, and then learning how to develop techniques to counter these thoughts. So we're almost at the end. So a few things in summary. Look for treatments, not cures. Try exercising. Try cognitive behavioral therapy. Definitely, start with things that have shown benefit, and have shown benefit in scientific studies, and that's where the physician comes in, who can recommend for certain things and against certain things. It's important to recognize that when you're trying, those treatments, you have to make sure that they're safe. You can't, you don't want to bundle up different medications all at once. You don't want, again, that's where your physician comes in, and they should be, guiding this process. I think I discussed this before. It's important to keep a diary of your symptoms, side effects, and then discuss it and report it to your treating physician. So when your symptoms get worse, again, don't assume it is because a treatment has stopped working. It could be because you're flaring up. Medication might not have kicked in yet. You might not be at the optimal dose yet. So there's a lot of variables. So it's important not to just simply assume it stopped working and it's time to give up on it. So don't stop your existing treatment. We'll look to add new treatments. I think I talked about this, that the fibromyalgia, waxes and wanes. You have to look for extraneous factors in your life that could be potentially causing these flare-ups. And the very last thing at the bottom of the slide, and that's really important. As you are exercising, as you're increasing your activity, it's important to continue to increase your activity as tolerated. Okay, so don't rest on your laurels, so to speak. If you tolerate it well, then you should keep going. You can continue ramping it up. It's an important point about disability. We do see patients sometimes who come asking for disability. Again, what we see in practice is that unfortunately disability essentially becomes a vicious cycle, so to speak. Patients only get worse. So generally, we recommend against seeking disability for fibromyalgia. Most patients treated with existing therapies get better and can live normal lives. There are quite a few success stories. Medications work, non-pharmacological approaches work. So it's important to recognize that there's quite a lot of studies are ongoing in fibromyalgia, and hopefully there's a lot of new, better and more efficacious things on the horizon. Just a few resources that I wanted to point out at the bottom of this slide. There's a fibromyalgia support group that meets once a month on a Wednesday. Here's a contact email address. And the very last thing is a website. It's an excellent resource, a set of self-directed modules developed by University of Michigan, the fibromyalgia group where Dan Claw works. Just a fantastic resource, and you can do it at your own time, on your pace. Just a lot of good exercises. So I think this is it. We're at the end. If anyone has any questions, comments, I'll be more than happy to answer them. Thanks for your time and attention.
Thank you.